Hello, everyone. Thank you very much for joining us on this interview. Today, I'll be interviewing Dr. Latorre and Dr. Caviness, who are the main authors of a new myoclonus classification that was published in the Parkinsonism and Related Disorders journal in March of 2024. Good morning to both, and thank you so much for joining us.
You're welcome. My pleasure.
My pleasure as well. Thank you.
My first question is, how does this new IAPRD classification differ from the 1982 classification that was developed by Marson, Hallett, and Fan, and why did we need a new development?
We feel that, over the years, the old classifications, served us really well. But as the years and eventually decades went by, we all begin to feel, I think, that it was, just aging. And it was based really upon four broad etiological categories: physiologic myoclonus, essential myoclonus, epileptic myoclonus, and symptomatic myoclonus. But with advances in areas like genetics and neurophysiology, the terminology was really becoming quite outdated and in some cases just, frankly inaccurate. For instance, essential myoclonus, the vast majority of essential myoclonus are genetic etiology of the myoclonus dystonia syndrome. So it really was just beginning not to be very useful. We also knew that the classification schemes for tremor and dystonia had been overhauled, basically, and it would make more sense if we applied those principles to myoclonus. And so the differences are switching from a very old etiological classification scheme with very old and outdated terminology to a newer model that allowed for more exact terminology of clinical characteristics as well as etiologies of myoclonus.
Okay, thank you very much. So how was it initiated? How did you take the initiative, and what method do you use to produce this classification?
Really, the credit for that goes to the International Association of Parkinson's Disease and Related Disorders. A couple years ago, Dan Charong was president of the association, and he contacted me and asked me if I'd be interested in leading a group to look at the current classification and basically overhauling it. Basically, there was no other request but that, and so then I began to talk to people like Anna and Marina and many others about how that might happen. And we did immediately think of the classification schemes that were recently published for tremor and dystonia and doing something similar. We knew we were going to have to make some changes to the basic structure because it was a myoclonus. And so then we've formed a group, a 15-member panel, all experts in myoclonus who, all kindly agreed to their time and effort. And we began to think about, well, how should we, run this? Do we just let a couple of people kind of decide everything and see if everyone else agrees? But then there was a suggestion of something called the Delphi panel method, in which it's more egalitarian, in which there's surveys, everybody gets a voice, and a consensus is built by basically voting in the Delphi panels.
Okay, so you mentioned the Delphi panels, and this supported the axis approach that we saw in publications about dystonia and tremor that you also mentioned. So what is the rationale behind the scheme of, the axis approach and the Delphi consensus?
So in developing this new myoclonus classification, as you said, we align our approach with the axis system that was recently used for other movement disorders. The system introduces two axes, which is one focusing on the clinical features and the other one on the etiologies. This is an important approach because it mirrors our clinical practice. So where diagnosis begins with observing patient signs, taking thorough medical history, conducting neurological examination to define the disease phenotype. Recognizing specific symptoms combination allows us to identify clinical syndrome, guiding our differential diagnosis. Once we have identified the clinical syndrome, then we can explore the potential etiologies. So this two-axis classification for myoclonus, similar with dystonia and tremor, reflects this natural clinical approach. And if we look into the axis a little bit more in details, what we can say about axis 1 is that beyond the usual clinical information, we incorporate specific details pertinent to the diagnosis of myoclonus. For instance, the anatomical distribution, such as focal, multifocal, generalized, but also proximal and distal in the limbs. Activation state, such as resting, action-induced, stimulus-sensitive, and temporal profiles, such as constant, paroxysmal, and rhythmic, which provides a relevant information guiding diagnostic consideration on the myoclonus subtypes and therefore the syndromes. Regarding axis 2, we categorize etiologies into genetic, acquired, functional neurological disorder, idiopathic, and physiological. We choose not to list specific examples of etiologies because the list is extensive and continually evolving. I just wanted to mention one important aspect about axis 2, which is the inclusion of the functional jerks, because although they are not conventionally considered myoclonus, functional jerks are critical to their high incident and significant impact in clinical practice.
Thank you very much. So the axis 1B neurophysiology was introduced, and you mentioned that. What are the pros and the cons of this new axis 1B?
I think this is one of the most important aspects of this classification and a novel step. Indeed, historically, myoclonus has been closely associated with the neurophysiological characteristics and presumed pathophysiological sources. Before discussing pros and cons, I would like to add just to highlight two aspects. One is the inclusion of cortical-subcortical myoclonus category, which is novel compared to our previous practice, and this generated some interesting debate. We agreed to add this category based on underlying physiology reflecting abnormal bidirectional excessive neural activity between cortical and subcortical circuits produce diffuse excitation, as seen for instance in myoclonic epilepsy, which is different from cortical myoclonus. The second aspect is again about functional jerks, because similarly to axis 1A, it implies an etiological diagnosis, but was included due to its clinical relevance and also neurophysiological markers. Now, to answer to your questions, I will address the cons first. And there is a lack of consensus of specific neurophysiological criteria. And this is why we couldn't give further details. Efforts to define the myoclonus clinical neurophysiological criteria have been made over the years, but there are limitations due to lack of systematic assessment and standardized methodologies. Despite acknowledging this limitation, we believe it is important to provide guidance on this aspect to clinicians and researchers, essentially offering a common starting point from which more solid criteria can be built over time. Now, if we turn to the pros, the biggest advantage of including axis 1B is that it finally gives us a structure framework for interpreting neurophysiological findings in myoclonus. So now we have some agreed upon or homogeneous criteria that clinicians and researchers can reference, even if they are not perfect yet. But this is a crucial first step.
Thank you very much. So how this new IAPRD consensus classification, how would that help in practice?
I think this new classification is really a game changer for clinicians. It brings together all the fragmented ways we used to classify myoclonus by syndrome, by cause, by physiology into one coherent structure. And this is a huge step forward. The fact that myoclonus can originate from multiple parts of the central as well as peripheral nervous system means its presentation can be extremely varied. And the variability can make the localization and diagnosis quite tricky. So having a classification that incorporates all these dimensions helps clinicians navigate this complexity more confidently. Then the two-axis approach is particularly helpful. Axis 1 helps to define the clinical syndrome. Axis 2 guides the clinician thinking about possible etiologies. And also by emphasizing neurophysiological classification, we hope to encourage clinicians to use these tools more routinely and to do so using standardized criteria. I think that another exciting outcome is that this framework could help open conversation between movement disorder specialists and epileptologists. Myoclonus often sits in borderland between the two specialties, but historically we haven't always had a shared language or approach. While this classification, adding for instance the cortical subcortical category, highlighting the importance of EEG abnormalities, might help bridge the gap and foster more collaboration. Finally, while we acknowledge the classification limitation, it provides a structure that can evolve. It invites updates, validation, studies, and deeper understanding of myoclonus moving forward. So for clinicians who sometimes feel a bit lost in this complicated disorder, we think that classification offers direction for diagnosis, research, and ultimately for patients' care.
That's great. That's fascinating. Thank you so much for making our life easier. So thank you so much, Dr. Latorre and Dr. Caviness, for your time, for your explanation, for your expertise. Again, my name is Raja Mehanna. If you want to read the whole article, it's available online. It's in the PRD Journal, the issue of March 2025. Thank you so much.
Thank you.
Thank you.
That's great. That's fascinating. Thank you so much for making our life easier. So thank you so much, Dr. Latorre and Dr. Caviness, for your time, for your explanation, for your expertise. Again, my name is Raja Mehanna. If you want to read the whole article, it's available online. It's in the PRD Journal, the issue of March 2025. Thank you so much.
Thank you.
Thank you.